Start now. Good afternoon and good morning for our Spanish colleagues. Then I'm very happy and very honored to be invited by Mintam Group to join this very interesting scientific symposium organized by the University Medical Center, Ho Chi Minh City, Vietnam, and Mintam Group, the local distributor of Beckman Coulter. So we all know that sepsis and septic shock is always a very hard and very challenging topic that we need to invest more energy, more time, and more knowledge. So that's why this afternoon or this morning for the European speakers, we organized this symposium to supply the knowledge to the local Vietnamese doctor. I'm very honored to introduce to you Dr. Alba Herraiz and Dr. Fernando Arméstar from University Hospital German Trias I Pujol from Spain, and Dr. Paul Ziwei. She's Scientific Market Director of Asia Pacific of Beckman Coulter. So not to waste your time, I will start very straightforwardly. First of all, I would like to invite Dr. Alba Herraiz and Dr. Fernando Arméstar to give a lecture on early detection and management of sepsis. So please. So you will use your computer, or we will share the slides for you?
Fernando,
Mở cái micro của Fernando lên.
You're on mute.
So
could you please hear?
Yes.
Can you hear me?
Yes.
Yes. Okay, we are going to start. Good morning from Badalona, Barcelona. Before starting, we would like to thank the organization for the kind invitation allowing us to speak on the important subject of early detection and management of sepsis. This presentation will be divided into two parts. The first part will be presented by me, and the second part by my colleague, Dr. Alba Herraiz. We are participating on behalf of Hospital Germans Trias y Pujol, and we must include this disclosure. We are working in collaboration with Beckman Coulter. The agenda to be discussed will be global guidelines on early detection and management of sepsis from the emergency department to the intensive care unit. Current clinical experience in Badalona, management of sepsis in patient journey from the emergency department to the intensive care unit. Usage of procalcitonin, PCT. A new parameter for sepsis detection, experience with monocyte distribution with MDW, performance in intensive care unit. Future introduction of MDW in daily practice for the detection of sepsis. Sepsis and septic shock are major healthcare problems that affect millions of people around the world each year. The mortality rate is more than 25%. Every year, sepsis affects 30 million people worldwide, 3 million newborns, 1.2 million children. Every year, sepsis can kill 6 million people, kills up to 500,000 newborns, and causes 1 in 10 maternal deaths. But the interesting thing is that we can prevent sepsis by preventing infection and preventing the evolution of infection to sepsis. In 1992, in the journal Critical Care Medicine, the definitions on sepsis, organ failure, and the sepsis treatment guidelines were published. This is a very important paper because it tries to clarify concepts that were still confusing. From my point of view, this figure, placed in the aforementioned publication, details important interrelations with different pathologies and highlights the differences and similarities that may exist between them. If we look at the systemic inflammatory response, we can see that it can include pancreatitis, burns, trauma, and sepsis caused by fungus, bacteria, and virus. Here we can already see the difficulty in differentiating the different pathologies and can cause a systemic inflammatory response in the body. There is a similar problem with infections because an infection can have a systemic inflammatory response or not. The same thing can happen with bacteremia. In summary, we can see the spectrum of the systemic inflammatory response is quite wide, and that an infection will not always be classified as sepsis. These are the definitions written in this publication. We will call them Sepsis Definitions 1, so that we can see the evolution of sepsis terms from this point on. Infection is defined as a microbial phenomenon characterized by an inflammatory response to the presence of microorganisms of the invasion of normally sterilized host tissue by those organisms. This response can be local or systemic. Bacteremia is the presence of viable bacteria in the blood. Another important definition is the systemic inflammatory response syndrome. This is the systemic inflammatory response to a variety of severe clinical insults. The response is manifested by 2 or more of the following conditions: temperature higher than 38 degrees Celsius or lower than 36 degrees Celsius, heart rate superior to 90 beats per minute, respiratory rate superior to 20 breaths per minute, or partial pressure of carbon dioxide inferior to 32 millimeters of mercury, more than 12,000 white blood cells per cubic millimeter, less than 4,000 white blood cells per cubic millimeter, or a percentage of more than 10% of immature forms. Sepsis is defined as a systemic response to infection. This systemic response is manifested by 2 or more of the following conditions as a result of infection: temperature higher than 38 degrees Celsius or lower than 36 degrees Celsius, heart rate superior to 90 beats per minute, respiratory rate superior to 20 breaths per minute, or partial pressure of carbon dioxide lower than 32 millimeters of mercury, more than 12,000 white blood cells per cubic millimeter, less than 4,000 white blood cells per cubic millimeter, or a percentage of more than 10% of immature forms. Severe sepsis is defined as sepsis associated with organ dysfunction, hypoperfusion, or hypotension. Hypoperfusion and perfusion abnormalities may include, but are not limited to, lactic acidosis, oliguria, or an acute alteration in mental status. Septic shock is sepsis with hypotension, despite adequate fluid resuscitation, along with the presence of perfusion abnormalities that may include but are not limited to lactic acidosis, oliguria, or an acute alteration in mental status. Patients who are on inotropic or vasopressor agents may not be hypotensive at the time that perfusion abnormalities are measured. Hypotension is defined as systolic blood pressure lower than 90 millimeters of mercury or reduction more than 40 millimeters of mercury from baseline in the absence of the other causes for hypotension. Multiple organ dysfunction syndrome is the presence of altered organ function in acutely ill patients such that homeostasis cannot be maintained without intervention. A critical point in the understanding of the importance of sepsis is multi-organ dysfunction. The mortality rate in patients that present sepsis is correlated directly to multi-organ dysfunction. The slide on the left shows a small insect bite, and the other one shows a multi-organ dysfunction caused by the microorganisms transmitted through the bite. How does organ failure work? So the predominant events that take place in sepsis are arterial vasodilation and hypercoagulability. The consequences of these phenomena are hypoperfusion and organ dysfunction. In the clinical practice, you can see brain dysfunction, lung dysfunction with acute respiratory distress syndrome, liver dysfunction, heart dysfunction, digestive and metabolic disorder, kidney and adrenal dysfunction. The Journal Intensive Care Medicine published an update on the definitions the year 2003, having gathered them from the International Sepsis Definitions Conference of the year 2001. In said conference, these concepts were mentioned once again. Infection, a pathological process caused by invasion of normally sterilized tissue or fluid or body cavity by pathogenic or potentially pathogenic microorganisms. You can see that this definition is very similar to the one said previously. Sepsis is a systemic inflammation in response to infection. This time, however, we face the problem of the low precision of the definition of sepsis. Thus, a list of signs and symptoms of systemic inflammatory response to infection was added. The diagnostic criteria for sepsis are infection criteria plus some of the following: general parameters, fever, hypothermia, tachycardia, tachypnea, altered mental status, edema, hyperglycemia. Inflammatory parameters, leukocytosis, leukopenia, white blood cell with more than 10% of immature forms, and elevated plasma C-reactive protein and plasma procalcitonin levels. Hemodynamic parameters, hypotension, mixed venous oxygen saturation more than 70%, elevated cardiac index. Organ dysfunction parameters, arterial hypoxemia, acute oliguria, elevated plasma creatinine level, coagulation abnormalities, ileus, thrombocytopenia, hyperbilirubinemia. Tissue perfusion parameters, hyperlactemia, decreased capillary refill, or mottling. Severe sepsis, sepsis with organ dysfunction, this definition remained unchanged and refers to sepsis complicated by organ dysfunction. Severe sepsis is now considered to be the most common cause of death in the non-coronary critical care unit. And septic shock refers to a state of acute circulatory failure characterized by persistent arterial hypotension unexplained by other causes. Hypotension is defined by a systolic arterial pressure below 90 millimeters of mercury, mean arterial pressure lower than 60 millimeters of mercury, or a reduction in systolic blood pressure of more than 40 millimeters from baseline, despite adequate volume resuscitation, in the absence of other causes of hypotension. In 2017, the Journal of Critical Care Medicine published the guidelines about management of sepsis and septic shock. Here, the sepsis was defined as a life-threatening organ dysfunction caused by a dysregulated host response to infection. Septic shock is a subset of sepsis with circulatory and cellular or metabolic dysfunction associated with a higher risk of mortality. To understand sepsis, it is necessary to understand its pathophysiology. Sepsis is characterized by a simultaneous imbalance of hyperinflammation and immunosuppression. The pro-inflammatory phase is due to an upregulation of innate immunity, which induces a store of pro-inflammatory cytokines. The anti-inflammatory phase is produced by a suppression of adaptive immunity. There is a predominance of anti-inflammatory cytokines that inhibit monocyte activation, which cannot act as antigen-presenting cell. I'm showing the slide again to emphasize the importance of sepsis. How can this health problem be solved? Preventing infections, preventing the evolution of infections into sepsis, preventing the evolution of sepsis into septic shock, and treatment of sepsis and septic shock. Vaccines are very widely used of disease prevention. Thanks to them, many infectious diseases have been eliminated. Adequate nutrition is an important factor in maintaining an immune system in homeostasis. Hygiene is also essential. One of the simplest ways is hand washing. Reducing the use of antibiotics is imperative. With this, we will avoid eliminating the usual bacterial flora and we will maintain this barrier against infection. For the prevention of the evolution of infection into sepsis, early detection, immediate medical attention, and quick and appropriate treatment are necessary. I highlight early detection, which is what we will develop in more depth. For the prevention, the evolution of sepsis into septic shock, early detection, immediate medical attention, and appropriate treatment are necessary too. When dealing with sepsis, we can state that taking early actions saves lives. The attention must be quick both at hospital level as at an extra-hospital level. When an analysis of guidelines of surviving sepsis is made, two general conclusions can be drawn. The first is that the care must be protocolized, and the other one is that it must be prompt. The care of patients with sepsis consists of an initial resuscitation, diagnosis, antimicrobial therapy, and screening for sepsis, and performance improvements. In this point, the recommendation is that hospitals have a specific sepsis program that includes the detection of sepsis, and people at high risk of suffering should be highlighted. The early detection of sepsis is based on the assessment of clinical parameters, laboratory tests, we emphasize biomarkers, and imaging tests. In addition, the scales for the early detection of sepsis and the assessment of organ failure are extremely important. Within the clinical parameters, we can mention fever or hypothermia, tachycardia, tachypnea, decreased capillary refilling, alteration of mental state. The imaging tests that we use the most are thorax radiography, ultrasound, computed axial tomography, and magnetic resonance. There have been more than 170 biomarkers described, but none of them have worked out unless we include CRP and PCT, which are the ones we keep using routinely. Therefore, there is a pressing need for a biomarker that is routinely available during the initial emergency department clinical evaluation to enhance the detection of sepsis. PCT concentration levels in patients with sepsis and other clinically significant bacterial infections are elevated. In this graph, you can see that the PCT levels increase earlier than CRP in septic patients. PCT can aid in differentiating between viral and bacterial sepsis origin. What the guidelines tell us about procalcitonin is the following. Measurement of serum procalcitonin is commonly used in many parts of the world to assist in the diagnosis of acute infection and to help define the duration of antimicrobial therapy. Various procalcitonin-based algorithms has been used to direct the escalation of antimicrobial therapy in severe infection and sepsis. However, it is not clear that any particular algorithm provides a clinical advantage over another. Current guidelines on surviving sepsis suggest measuring procalcitonin levels to support us in the decision to shorten the duration of antibiotic treatment in patients with sepsis. Likewise, they suggest measuring procalcitonin levels to support the discontinuation of empirical treatment in patients with apparently have sepsis but subsequently have little clinical evidence of infection. This last issue is very important. For example, in the current coronavirus pandemic, antibiotic treatments have been used in the generalized way to treat a viral infection, with the argument that this patient can present both viral and bacterial infection at the same time. Okay, thank you for listening. The next one is Dr. Alba Herraiz will take over from here.
Okay, hello to everybody. I'm going to keep the presentation. Well, in this slide, to reinforce the scientific evidence, this study demonstrates that traditional biomarkers like lactate, procalcitonin, CRP, etc., have limited utility in the prediction of sepsis. Moreover, in the last edition of the Surviving Sepsis Guidelines, the Quicksoft Score was designed for the early recognition of sepsis. It includes 3 parameters: respiratory rate, altered mentation, and hypotension. And if 2 of the 3 parameters are present, we should suspect that the patient is suffering a septic process. As we can see, it exists some sepsis scores, SEERS, SOFA, Quicksoft, and LOTS. However, all of them are useful for the prognosis of sepsis, but not for its early recognition. If we compare the different sepsis scores between them, among ICU patients with suspected infection, the predictive validity for in-hospital mortality of SOFA was not significantly different than the more complex lots, but was statistically greater than SEERS and Quicksoft, supporting its use in clinical criteria for sepsis. Among patients with suspected infection outside of the ICU, the predictive validity for in-hospital mortality of Quicksoft was statistically greater than SOFA and SEERS, but supporting its use as a prompt to consider possible sepsis. Probably, SOFA score is the most famous and useful score because clinicians use it every day for the clinical practice. It includes different items, and each item represents one organ dysfunction. As you can imagine, the prognosis is worse in those patients with a greater number of organ failures. Now we are going to show you our clinical experience in our hospital and the management of sepsis in those patients who are admitted in the ICU from the emergency department. We have established an action circuit in all patients with high suspicion of sepsis. In fact, currently, we are updating the hospital protocol for the management of sepsis. We are faithful to the recommendations of the Surviving Sepsis campaign, and we have created the sepsis code in order to act properly and fast against sepsis. To achieve this purpose, it is absolutely necessary that different departments work together in a coordinated manner. Moreover, our objective is to spread the sepsis code to the rest of the hospitals of the area. And we think that it's extremely important that other hospitals participate actively in this project if we want to improve the prognosis of sepsis. When we suspect an infection, it is mandatory to obtain microbiological cultures, perform an image test, and request laboratory tests urgently. In the biochemistry parameters, we always add traditional biomarkers, procalcitonin, CRP, lactate, and in the near future, we would like to add a new biomarker for sepsis detection, the monocyte distribution width, MDW. It is thought that this biomarker could hold the key to alerting clinicians about the risk of sepsis earlier. Beckman-Coulter has addressed this need with the early sepsis indicator, which analyzes morphological changes in monocytes. Recent studies have indicated that volumetric increases in immune cells might be useful for detection of sepsis, and taken together with current standard of care, early sepsis indicator can augment the suspicion of sepsis or risk of developing sepsis within 12 hours. Early sepsis indicator measure the change in the size distribution of circulating monocytes, known as monocyte distribution width. Recently, the emergency department of our hospital and the emergency department of La Pitié Hospital from France have participated together in an observational study about the evaluation of the monocyte distribution width for the early detection of sepsis in the emergency department. The main objective of the study was to confirm the clinical validity and the performance of monocyte distribution width to identify patients who developed sepsis in an European emergency department population, and to verify the monocyte distribution width cutoff for K3 ETA tubes. The secondary objective was to compare the performance of monocyte distribution width with CRP and procalcitonin. Regarding materials and method, a blinded prospective observational cohort study was carried out in France and Spain. A total of 1,517 adult patients presenting to the emergency department were screened, and a completed blood count with differential tests was performed in all of them. 260 patients, 17% of patients, were categorized by sepsis 2 criteria, and 144 patients, 9.5% of patients, were categorized by sepsis 3 criteria. Sepsis was adjudicated by two. Sorry,
Dr. Alba, can you slow down a little bit, because
yes, sorry, yes, of course.
Slow down quite a bit.
Yes.
Thank you.
Sorry. Okay. Sepsis was adjudicated by two independent acute care physicians using current standard of care, sepsis 2 and sepsis 3, and discordances were arbitrated by a third independent physician. A completed blood count with differential test and also the monocyte distribution width was measured on Beckman-Coulter hematology analyzer, whereas procalcitonin and CRP were measured in our laboratory machines. A total of 100 septic patients in each hospital were included at the end of the study. Regarding the study design, after a patient presents to the emergency department and the initial triage indicates possible infection, a blood sample must be taken before 2 hours. A completed blood count with differential is ordered in addition to monocyte distribution width, procalcitonin, and CRP. Each patient is continuously assessed and followed up for 12 hours, and the diagnosis of infection should be done in those first 12 hours. Diagnosis adjudication using sepsis 2 and sepsis 3 criteria is established between 5 and 7 days later. Well, now I'm going to show you the results of combined data from La Pitié Hospital and Germain Trias Pujol Hospital. The median value of monocyte distribution width was 20.1, independently of sepsis 2 or sepsis 3 criteria. And as you can see, regardless of the sepsis criteria, the values of the monocyte distribution width were higher in the sepsis group in comparison with non-sepsis group. And the value of the monocyte distribution width increased with increasing sepsis severity. The sensitivity and the specificity of monocyte distribution width is 75 and 73% respectively. The positive predictive value is considerably low, just 36%, but the negative predictive value is notably high, 93%. And I think that the last piece of information about negative predictive value is quite relevant. Now, if we focus on comparing the performance of monocyte distribution with CRP and procalcitonin, we can see that the diagnostic power of monocyte distribution width was comparable to procalcitonin and CRP. However, the combination of monocyte distribution width and white blood cell count enhances the performance in those patients categorized in sepsis 2 criteria. Its area under the curve was 0.86. The conclusions. This study, conducted in 2 large European emergency departments, confirmed the performance of monocyte distribution width as an early sepsis biomarker with an area under the curve of 0.81 for sepsis 2 and sepsis 3 respectively, using a cutoff of 21.5 in K3 ETA tubes. Based on area under the curve analysis, the performance of monocyte distribution width together with white blood cell count exceeds the performance of both monocyte distribution width and white blood cell count for sepsis 2 and white blood cell count for sepsis 3. These results are in general concordance with the 2 recent North American studies, which reported the similar performance of monocyte distribution width, demonstrating the robustness and the reproducibility of this new biomarker in different populations. In the first comparison of monocyte distribution with procalcitonin and CRP biomarkers in the emergency department patients, the performance of monocyte distribution width was comparable to procalcitonin and CRP, but superior to procalcitonin when combined with white blood cell count. Adding procalcitonin or CRP to the combination of monocyte distribution width and white blood cell count didn't increase the diagnostic power. Monocyte distribution width and white blood cell count are available as a part of our routine completed blood count with differential, unlike procalcitonin and CRP, which are usually ordered only in patients with a high index of clinical suspicion for sepsis or infection. Combination of abnormal monocyte distribution width and white blood cell count measured at the time of emergency department admission may alert for potential sepsis even in situations of low clinical suspicion. So monocyte distribution width could help us for diagnosis of sepsis, but it could not be considered a definitive biomarker of sepsis. Monocyte distribution width is obtained easily from the hemogram, so it allows to act against sepsis in an efficient way. And monocyte distribution width determination can help clinicians in the early detection of sepsis in the emergency department. Well, we are going to change the department and we are going to focus on the ICU. And in our hospital, we also wanted to know the performance of monocyte distribution width on ICU patients. And for this reason, Beckman-Coulter designed a second study which is titled Monocyte Distribution Width Performance on Patients on ICU in an intensive care unit. The main objectives of the study were to establish the diagnostic value and performance of monocyte distribution width parameter to detect the development of sepsis in a prospective study of ICU adults, to study if the quantification of the monocyte distribution width correlates with a greater severity of the patients admitted to the ICU and with antibiotic effect, to establish if the combination with other biomarkers, such as CRP, procalcitonin, increase the diagnostic performance for the early detection of sepsis, and to establish whether the determination of monocyte distribution width improves sepsis detection times. We needed a total of 450 patients, and the inclusion criteria were patients consecutively admitted for more than 24 hours in the referred study period and have an age equal to or greater than 18 years. Well, patients admitted in the ICU are divided into 2 groups according to sepsis 3 criteria: the predictive group or non-infected group and the prognostic group or infected group. In both groups, we take blood samples periodically according to the protocol study. Well, our preliminary results are based on 364 patients enrolled in the study. However, 20 of them were finally excluded. 14 hematological patients with severe dysfunction of their bone marrow, and 6 more patients due to inadequate acquisition of their samples. From the total 344 patients, 199 were non-septic patients or predictive patients, and 169 patients were septic patients or prognostic patients. The cutoff of monocyte distribution width at admission for the predictive group was 20.4, and for the prognostic group was 29.7, and the difference between groups were statistically significant. We also have done a subgroup analysis to study the behavior of the monocyte distribution width according to the presence of infection and the severity of it. As you can see, the sample was divided in 3 groups: non-infected patients, septic patients, and septic shock patients. The cutoff of monocyte distribution width at admission for the non-infected patients was 20.4, for septic patients 26.8, and for septic shock patients 32.5. The differences between groups were statistically significant again, and it suggests that the value of the monocyte distribution width increases with the severity of infection, acquiring prognostic power. Regarding the ROC curves for analyzing the prediction of sepsis, the area under the curve of each biomarker was notably high and statistically significant, and the area under the curve of the monocyte distribution width is 0.88, which is greater compared to the area under the curve of the CRP and procalcitonin. In fact, the results are quite satisfactory if the cutoff of the monocyte distribution width is established in 21.5, being possible to acquire a sensitivity of 91% and a negative predictive value of 91%. According to these results, we also have analyzed the pre-test and the post-test probabilities, and the results are quite positive too. As you can see, the post-test probability is 10% when the result of monocyte distribution width is normal. It means that when the monocyte distribution width is under 21.5, the patient has just a 10% of probability of developing sepsis. Moreover, combining the performance of monocyte distribution width plus CRP and procalcitonin, it is possible to improve the prognostic power for the early recognition of sepsis, since the area under the curve of these 3 biomarkers increases up to 0.92. Well, now we are going to show you some examples. The first case is a predictive example. It was a 60-year-old man with the diagnosis of a stroke. As you can see, the monocyte distribution width values remain practically unchanged. The patient evolved positively and without evidence of sepsis. The second case is a prognostic. Example. It was a 39-year-old man with a diagnosis of septic shock due to cholangitis. As you can see, the monocyte distribution width values progressively decreased. The evolution of patient was favorable, achieving sepsis resolution. And the third case is a predictive prognostic case. It was a 44-year-old man with a diagnosis of a stroke. As you can see, the monocyte distribution width values increased sharply. The patient evolved negatively, who acquired a respiratory infection in the ICU, and finally he died. Well, in these 2 graphics, we can see the tendency of the monocyte distribution width in each group of patients. In the first graphic, the left one, the orange line represents the prognostic group, septic patients, and the green line represents the predictive group, non-infected patients. The variation of the monocyte distribution width in the predictive group remained practically unchanged during the observation period. And the variation of the monocyte distribution width in the prognostic group, however, decreased notoriously. It probably means that the management of septic patients was appropriate in the ICU. The second graphic, the right one, represents just the predictive group, non-infected patients on admission, okay? The red line represents non-infected patients that become infected in ICU. It means predictive prognostic patients. Whereas the green line represents non-infected patients that remain uninfected during its stay in the ICU. The monocyte distribution width in the predictive prognostic patients increases sharply the first 3 days of observation, and its value rises and remains above 21.5 during its stay in the ICU. Moreover, its tendency is decreasing, which it means that patients evolve favorably. These findings could be useful in our daily practice because if a non-infected patient increases its MDW above 21.5, it could mean that the patient is developing sepsis, probably prior to the clinical manifestations of the latent infection. Well, we just have the preliminary results, and at the moment we cannot conclude anything, but we are optimistic and hope that the final results will be positive. And I say that because, as I mentioned previously, we would like to include monocyte distribution width in our daily practice for the early recognition of sepsis. And the laboratory of our hospital is one of the most important labs of the area, and it will incorporate the necessary infrastructure for adding the monocyte distribution width in order to increase the diagnostic sensitivity of sepsis. This is a possible algorithm for patients under suspicion of sepsis. After a patient presents to the emergency department and the initial triage indicates possible infection, a blood sample must be taken urgently. A completed blood count with differential is ordered in addition to monocyte distribution width. Patients are continuously assessed and followed up because symptoms may only become obvious several hours after presenting to the emergency department. And this is where the results of the early detection test might indicate possible sepsis, leading to further tests, including traditional biomarkers, and the application of Quicksoft criteria at the inpatient stage. Finally, the conclusions. Sepsis is an important problem with a very high mortality rate. The early diagnostic strategies will contribute to diminish the incidence of sepsis and septic shock, and the use of monocyte distribution width will contribute to improve the treatment of sepsis and septic shock. That's all. We want to thank Beckman for offering us the opportunity to participate in this webinar and spread our knowledge about sepsis. We also want to thank our listeners of their effort and time. We know that we are living a hard situation due to COVID-19, and we are working under a lot of pressure everywhere. Now it is the time for questions and for discussing the topics that we have presented, and we are available to answer questions and solve possible doubts. Thank you. Thank you very much.
Okay. Thank you very much, Dr. Fernando and Dr. Alba. We know that Dr. Fernando have a very comprehensive review on the development of the different sepsis guidelines from sepsis 1 to sepsis 2 and current sepsis 3. And Dr. Alba have shown us very comprehensive studies on different situations in the ED and also in intensive care, and also give us the flow chart how to approach the septic patient or a patient with the septic shock. So because I was informed that you have no time for to join us until the end, so now we open the Q&A session. Vâng, coi thì có câu hỏi nữa. So let me see. There are some questions. So the first question to Dr. Alba. The combination between MDW and white blood cell count, PCT, or between MDW and white blood cell count, CP, seem not to be superior in sepsis 3. Can you give more comment on that? Can the MDW be performed in the lab of a resource-limited setting like in provincial hospital in Vietnam?
I think that our results can could be applied in your area, because we just need an hemogram. Yes, white blood cell count just need an hemogram, and an MDW just needs an hemogram. So you can apply this formula, the combination of MDW and the white blood cell count in a local hospital without problem.
So another question is for you, always the same question. So how do you feel about the use of SOFA as a criteria for diagnosis of sepsis? Because some people say that it look like a prognostic criteria than the diagnosis criteria.
Yes, I agree. I think that SOFA is a prognostic tool instead of diagnostic tool. For the diagnosis of sepsis, we need different tools, and I think that SOFA score is a prognostic tool. It let us to know the prognostic of the patient under sepsis condition.
So are you waiting for the new sepsis score in the recent the years next to come? Right now we use a sepsis 3.
Yes.
And currently you use your study, you use even sepsis 2 and sepsis 3. But why do you use at the same time 2 criteria? What is that?
We are using sepsis 3 criteria. Okay.
Yeah.
And we need SOFA as a prognostic tool. We don't use SOFA score for the diagnosis of sepsis.
And when you move from the ED to the intensive care unit, what do you feel about the applicability of MDW in the population of patient in ICU? Because the ICU patient is quite different from the ED patient. The purpose of MDW is due to early detection of sepsis. So in the ICU, the situation is quite different. So what do you think about this?
Okay, as you can see, the value of the monocyte distribution with MDW is the same in the emergency department than in the ICU. And the most part of the septic patients and septic shock patients come from the emergency department. So we, at our admission in the ICU, we have the evolution of the sepsis process, okay? So I know that the patient is different because their prognostic is worse than in the emergency department, but currently we are going to use the same cutoff of the monocyte distribution width, because it's the best cutoff in the emergency department than in the ICU.
Yeah, another question comes to you. May MDW increase in other diseases with strong inflammatory response as well, such as cancers or autoimmune diseases? Not in sepsis, but some other disease that have the source.
Yes, in our study we have excluded some patients like hematological patients, but we have a little subgroup of patients like pancreatitis or SIRS patients that their monocyte distribution width is high, is as bigger as our septic patients.
Okay, one very practical question, maybe for you or for the company. Can we add a chip in the laboratory or analyzer to generate the MDW instead of buying a new analyzer?
Actually, I can maybe take that question. No, we cannot add a chip to look at MDW. You will need the Beckman-Coulter hematology analyzers, because the data that has been FDA approved was run on the hematology analyzer. even though I understand that maybe this parameter may be similar across different platforms, but I think the key is that regulatory authorities have approved it because the data generated was run on the DXH 900.
So the Beckman quota will reduce the price for the developing country like Vietnam. Sure.
You have to discuss with me, Taleb. But noted.
Okay. Because we have no more question, so I would like to thank to Dr. Our Spanish colleagues for your wonderful lecture on the overview of the sepsis, and also in very updated information on the use of MDW in early detection of sepsis in patient in ED and also intensive care unit. Thank you very much, because I know you are clinician, you are very busy. So thank you very much for your time. And I think I would like to say goodbye to you, so you can be back to your routine work. I think it's very busy now in Spain.
Yes, thank you very much. It has been a pleasure. Thank you.
Okay. So now I will switch to my lecture in Vietnamese. So Dr. Wei, you can stay there, or you can have a cup of coffee, and then I will invite you to join us